Recording started.
If for whatever reason I fade out, so just send me a little text, and then we'll try to adjust as needed. So first of all, thank you for everybody for joining this talk, and really thank you to the different organizations in making this happen. And I'll just continue on, and if you have questions, you can type them at the side as well, and I'll try to answer if it fits in. If I'm ignoring your question, it's not because I mean to. It maybe the answer will show up a little later. So who am I? I'm a physiotherapist working at Hamilton Health Sciences in Hamilton, Ontario, Canada. I work on a hematology, oncology ward. I am a clinical specialist in oncology, and I was certified through the Canadian Physiotherapy Association. In Canada, we have an oncology division, and I'm the chair of that group. In my spare time, I'm also working on my PhD through McMaster University and a few other things. And if anybody has questions, you can feel free to contact me. My email is on the slide there as well. So one thing I do want to say, at least in Canada, physiotherapists do not diagnose metastases. However, I think we need to have a common language with doctors and others on our team when we worry about metastases. So I really want to make sure that you know our job is not to diagnose the metastases, but we need to understand them because they affect how we work with our patients. I didn't include any pictures from the web. There's copyright limitations related to that, but I have provided links to where good pictures are available that can help you learn. And I've included a reference here as well, and this reference is freely, or the full article is available on the web. And even though it's not physiotherapy related, it does give a good explanation about metastases. So what do physiotherapists do for people with cancer? We do a lot of things. We do, hopefully, safe exercise is a big thing of what we do. We improve quality of life. We maximize function. And I think we can improve survival with our tools, and the main tool for that is exercise. And if you're interested, we can have a discussion if we can prevent cancer or not. And I won't answer that question. I just think it's a good point to discuss. And I won't mention that today, but it's really something that I promote and challenge physiotherapists to think about. So my goals for this talk is really that by the time you're done listening to me, you'll have a basic understanding of metastatic cancer. I'm going to focus primarily on bone metastases. You'll have some understanding related to safety when working with people with cancer, and how we can work with people who have been diagnosed with metastatic disease. And this is the flow of my talk, and let's get started. So what are metastases? Metastases are cancers that spread from where they came from. So some people may have two cancers. They both may be primary, and we see that regularly in our practice. However, some people have one cancer that spreads to somewhere else, and the cancer that spread to somewhere else is named after where the first cancer came from. It is important to know that most metastases can be treated, and the treatment, I'll talk a bit more about treatment later on. But it's also important to know that most people who were diagnosed with cancer, they die as a result, direct or indirect result of the metastases. There's many types of cancers. There's over 200 different diagnoses of cancer. Almost all of them can have metastases, but some tend to spread easier, seems to be easier versus other cancers. There's many reasons why metastases will happen and where it will go. They really can go, metastases can spread anywhere. However, they tend to spread in somewhat of a predictable manner. Traditionally, they tend to go to lungs, bones, and liver. However, they can go anywhere else in the body. The ability of a metastasis, and I use the word successfully, I don't think it's really success that somebody has them, but it is a complicated process. And if you look at the article that I mentioned at the beginning, and as Jackie said, this session is recorded, so if you didn't have a chance to write down that reference, you can go back to it later. It's a complicated process, and it depends on many different things to have and develop a successful metastasis. But if it happens, it's a challenge for it to happen. And another important thing, some people may have metastases and it won't affect them forever, and some people it will. So that is something, especially for some types of cancers, it is important to know that the treatment may be focusing on preventing metastases. It's assumed that the metastases are there, but the treatment is preventing them from growing. So this table does not need to be memorized, and I won't have an exam at the end. These are just some examples of types of cancer and where they tend to spread to. The underlying words or the cancer types that are underlined means that the metastases tend to go to the lymph system as well, and the lymph system will be part of the top 3 targets, but instead of writing down lymph for all of these, underline was a bit easier. So really, it can go anywhere. However, they seem to have a predictable location where they tend to go, and I'll talk more about that as well. The most common sites tend to be, when we talk about bone metastases, tend to be the pelvis, the long bones, the femur, vertebrae, which is important for us, ribs, skulls, and really the long bones. So when somebody develops cancer, I mentioned it's a bit more of a complicated process for it to spread. The first stage of the spreading is the cancer grows out of its small little location, and it invades normal tissue around where it's been developed. Then it tends to invade the vascular system and travel in the circulation. Then it needs to somehow get out of the circulation. It often gets stopped in capillaries, seed itself in the new location, create what we call micrometastases, and then stimulate the growth of blood vessels to that metastasis so it can grow into a cancer that affects the body. So again, this is really point form, but it is a complicated process. There's actually, if you search metastases development on YouTube, there's a few very good videos to show the whole process. Simplified, but pretty good videos. So what are the signs and symptoms of metastases? So the answer is easy. It depends. So it's really not that easy. And as I mentioned, and as you saw from the table earlier, the metastases can happen anywhere, and the signs and symptoms will depend on where the metastases went to. So for example, if somebody had metastases to their brain, they may have headaches, seizures, dizziness, symptoms like that. If they went to a bone, they may have pain, fractures, or things like that. So as physios, that is important to us when we work with somebody with cancer. And I'll emphasize that probably a few more times throughout the talk as well. The treatment for metastases depends on the type of cancer. It may be systemic, and systemic may include chemotherapy, biologicals, hormone therapy. It may be local. If somebody has a metastasis to the femur, they may decide to fix that, put pins and plates before anything happened. It may be radiation. And of course, it may be a combination of several different treatments. And there's lots of new research looking at different methods to treat metastases as well. So from here on, I'm going to really focus on bone and lung metastases, even though other metastases can affect our treatment and how we work with people. These are one of the more common ones that we'll see. Depends where we practice, especially if some of you practice in a community setting, a private clinic or anything like that. And you see often people who come in for orthopedic problems. Those are the ones you may see often. And really, both of these groups are groups of people where we can do a lot of good work with. So a smidge on normal bones before I talk about bones with metastases, and I'm sure there's many of you out there who are greater experts than I am in bone physiology, but really what I want you to have a look and pay attention is how a bone is built in terms of it has a center cavity, and when I talk more about diagnoses, that will be relevant, and the spongy bone inside, and somewhat similar shape in, let's see if I get the pen working. There we go, somewhat similar shape in the vertebral body. So just pay attention a bit to how the bones are built. And the way bones are formed, and again, very basically, we have the osteoblasts who form bone and osteoclasts who are involved in bone absorption. And the key point for healthy bones is there's a balance between the activity of both of these cells, the osteoclast and osteoblast. And I provided you a link for a pretty neat video who demonstrates their activity. And for a normal bone, we need, of course, weight-bearing activities to be healthy. We need our calcium, vitamin D, and we need the balance of these two cells in their function. When somebody develops metastases, really what the metastases do, they affect the balance between those two cells. And there's different types of metastases. There's what's called osteolytic metastases, so that's commonly seen in people with multiple myeloma, where it looks like there are holes in the bone if somebody looks at the X-ray. There's osteoblastic metastases, and that's where the bones look thicker than the area around them. So if there's an X-ray, it tends to show up more white. And there is a link shortly you'll see to some pictures that show that. And many people have mixed types of metastases. When they do develop metastases, it's really mixed. And there's differences of opinion out there if osteoblastic, where the bones become or develop a tumor that makes the bone harder, is the bone fragile or not? And personally, and from some of my reading, I believe that even if the bone has an osteoblastic lesion, it's still not normal bone, and often it comes on the account of bone elsewhere. So I think at that point, at least what I recommend and the way I follow, I consider both of these types of lesions worrisome when I do exercise with patients who have them. From a medical point of view, it may be different to differentiate it. From our point of view, definitely people with osteolytic lesions tend to have more fragile bones. However, those with osteoblastic lesions also, I would consider their bones at the risk for injury. And this is the web page, and you can check out this web page, and it has a good article talking about diagnosis of metastases, and it shows very good pictures. And again, it's freely available. There's no cost to see it, and you can compare X-rays and different diagnostic methods. So the frequency of metastases by bone metastases by tumor type. So these are the incidents. I actually find it interesting that for multiple myeloma, there's different incidences, less than 100. The main reason is myeloma by definition is a disease of the bone. However, some people may not have a diagnosis that may have been found because of kidney problems. They may have been diagnosed with multiple myeloma, and they may not have bone lesions yet as well. So what's the importance of metastases when somebody is diagnosed with cancer? Often there's pain, and there may be many different reasons why people have pains from metastases. It may be pressure on nerves. It may be because they're occupying space. It's not clearly understood why. Metastases tend to secrete different hormones, and that may be cause of pain. Often people with metastases, they have loss of function, reduced quality of life, I mentioned the risk of fracture, and we'll talk about that again. If somebody has a primary cancer and then they are found to have metastases, it does imply disease progression, which means they may need more cancer treatment, which of course does affect quality of life and function. And there's medical complications such as hypercalcemia, and that's when calcium is released into the blood. And I will talk a bit more about that as well, because that's something we need to know about. In terms of disease progression, so for example, if I use people diagnosed with breast cancer, if somebody has metastases, is diagnosed with metastases to a bone only, their survival time can be, the median survival is more than 2 years, and it can actually be many, many years. However, if the metastases go to the visceral organs, their median survival is less than 1 year. And if somebody has bone metastases and they have a pathological fracture related to that, it's an independent factor for poor prognosis of overall survival. So it is important to be able to identify metastases early and, if possible, prevent them. So I mentioned the website where you can look at different pictures. What's important to know, there's often metastases can be diagnosed with an X-ray. However, if you consider the osteoblastic metastases, where you have where you have the osteoclastic metastases, where you have the hole in the bone, it really only shows on X-ray when there's 30% of the cortical bone loss. So metastases may be there for a while, and it may put the bone at risk for injury. However, it may not show on the X-ray. Bone scans are used if available where you work. They tend to show mostly osteoblastic metastases. CTs can work, but they're not really as good, because if there's inflammation, and bone scans, if there's inflammation unrelated to metastases and there's just increased activity in that area, it may not be 100% accurate. And there's different other tests as well. Often if you're monitoring hypercalcemia, so different biochemical markers, it may not be an indication that there are metastases. However, if it's known that there are metastases, monitoring similar things can be useful to say if the treatment that the person is getting is effective or not. The different type of treatments, again, depends where the metastases are. So for example, many of my patients who have multiple myeloma have pain related to some of their tumors, and often we use radiation therapy, external beams, where they can help shrink the tumors and help with pain, or they use the radiation to some degree, damage the local innervation, pain in the nerves in that area, again to reduce pain. Often radiation is used to prevent a spinal cord compression or prevent fractures. One important note is sometimes for some of our people, if they have a pretty big tumor in their spine and they use radiation to shrink the tumor, the spine may become actually unstable afterwards, and they may need surgery to stabilize their spine. So it's just something to consider. It depends how big the metastases was in the spine. Systemic therapy, such as chemo, it could be for pain, it could be for controlling the cancer. Again, depends on the type of cancer who metastasize. We often, before we send people to rehab at our hospital, and we know that they have metastases in their femur, for example, or in their humerus, we may ask our orthopedic services to check to see if those bones are stable before we go and exercise them. And they may or may not do preventative surgery to avoid fractures before we actually work hard with our patients. Kyphoplasty, which I won't talk about, however, it's a really neat surgery to help stabilize the spine, often used for people with osteoporosis who have compression fractures. It's really neat in the way that, it's really minimally invasive type of surgery, and more often than not, it has really good results in terms of pain control and stability. Of course, external braces are sometimes used if that's indicated. It had some challenges with it in terms of patients using those braces correctly and how they affect the ability to do a person ADLs and what they need to do. And bisphosphonates, which is a medication, and as I indicated, I'll talk about them now. And there's many different types of anyway, I won't say that. If this medication, and as a presenter, I have the privilege of not saying words on my slide. Each type acts a little differently, but really the main idea of these medications is to reduce the burden of metastases. It may reduce there's evidence to show that people who are on bisphosphonates have less or develop less metastases, and they have overall improved survival. And this is a medication that helps reduce the hypercalcemia in the blood. So it's really an important medication, and there's more and more research going into it right now in terms of preventing metastases and improving quality of life and improving survival as well. It does have side effects, just like any other medication, and it is important to notice them. So for example, if we have a patient on these medications and they have new bone and joint pain, what we need to do is try and figure out, is it related to the medication, is it related to metastases progression, or it's not related to anything from their cancer. So these are things that we need to know how to pay attention to. So really, why should we care? Why should physiotherapists care about metastases? One of the reasons we should care is we may be seeing people with cancer at any clinical setting. People with cancer now live a long time, and purposefully I'm not going to use the term chronic disease, because even though I have used cancer as it being developed to a chronic disease, I've decided to change my opinion on that, so that will be a different discussion. But people with cancer live a long time now, and we may see them anywhere. They go back to sports teams, we may see them in private practice, hospital, home care, really anywhere. And since there's many types of cancers, I don't think we can really know and learn everything about all the different types of cancers, but we need to know how to ask patients about their cancer, and with that knowledge and our knowledge of physiotherapy, how we can develop unique precautions and contraindications for each of our patients. And personally, I think when somebody is diagnosed with cancer, while the first few orders on the doctor's sheet may be their chemotherapy, one of them on the top 10 for sure should be a referral to a physiotherapist. And we can be involved in preventing a lot of complications related to their cancer, and of course related to their treatment for the cancer. So I really think physiotherapists have a great role to do in people with cancer. Thank you, Jackie, there for the note. So we're working on that, and that's definitely in Canada something we're trying to get all the physicians to appreciate. People with cancer often have complicated challenges. It's not just their disease. There's a lot associated when somebody's diagnosed with cancer. And that's really where our expertise and our ability to look at different aspects of a patient as physiotherapists come into play. And often as physios, we are able to modify our plan while we work with people, especially as we become more experienced. We may go in to work with a person with cancer, and then we need to deal with issues related to dying or something like that. So as physios, I think we're well equipped. We have a lot of knowledge how to deal with those types of situations. Also, people with cancer, generally speaking, even if they're told that their cancer is cured, they are at increased risk of recurrence or developing other cancers. So we are also equipped to help identify that as well. And there may not be somebody is diagnosed with cancer. There's not a clear flow for recovery. So if you look at this example of osteoarthritis, generally speaking, if somebody's active, the more active they are, and while we do use exercise, our tool, if somebody goes and runs every day or does high jump or whatever. They, of course, may have knee pain. They may have arthritis, and many people, more and more people have knee replacements. Hopefully before they have a knee replacement, they go to physio because there's good evidence we can help prevent and even delay the need for a knee replacement. They may or may not have surgery. Let's say they have surgery, they recover, and they may return to what they did before. If somebody has cancer, especially if they have metastatic disease, really the course following diagnosis is not predictable. There may be breast surgery, there may be lymph surgery, there may or may not be chemo, there may or may not be radiation. Definitely if it was spread throughout the body, all of those will be included. They may or may not go on hormone therapy or other medications. And really, what I'm trying to get at, it's not a straightforward plan. So generally speaking, if we talk about somebody who has a heart attack, so a heart attack happens, they feel really bad, they go to the hospital, they get their medication, they go to cardiac rehab, hopefully led by physiotherapists, and they get better and they return to a more active lifestyle and they feel better. Many people with cancer often feel well, and then they get diagnosed with breast cancer, then they get the treatment and they actually feel bad because of the treatment. And only later on they'll feel better, and we are the ones to help them feel better. So I like to say that as physios we need to be specialized generalists. And for anybody working in oncology, really we need to know how to deal with the symptoms we see, but we need to really be highly sensitive to psychological issues and how the cancer can progress and how it can affect our patients. In generalists, it's not that we necessarily have low quality skills. I think we have high quality skills, but really if somebody has cancer in their head, we need to know how to do ABI, or acquired brain injury physiotherapy. If somebody has a spinal cord compression from their cancer, we need to know how to do spinal cord physiotherapy. If somebody has a femur tumor, we need to know how to manage that. So really we need to know how to manage head to toe, and that's where the generalist part comes in. Cancer can affect anybody, any gender, any age. Generally speaking, the primary risk factor for cancer is increased age, but unfortunately we know many young people diagnosed with cancer as well. And as somebody gets less younger and they have cancer, often there's other comorbidities as well, diabetes. Many of our patients are obese, and we need to know how to deal with those situations as well. So really what we need to know is we need to have general ideas about cancer, but we need to really identify each patient's unique personality, how they're coping with the disease, and how their treatment is affecting them. And one thing in physio in general, but definitely in oncology, the routine is that there is no routine. We never know what will happen when we go see our patient. For example, a week or so ago, I was going to go do a relatively simple walk with the patient just to get them moving so they could be strong enough to go to rehab. And I ended up spending an hour working as a social worker. And the main reason that took a while to figure out is the patient didn't know if they're going to live or die. They didn't even know percentages. They thought they're dying, and the wife thought the patient is dying. And everywhere I looked in the chart, there was no indication of that. And I couldn't do any of what I wanted to do as a physiotherapist until I solved their social, their stress, and those challenges. So really, when we go in to see a patient, we need to be able to adjust our treatment on the go. And our treatment may not be what we planned when we go in. So I'm going to talk a bit about spinal cord compression. And that's when, and I'm talking about secondary spinal cord compression related to a cancer that metastasized to the spinal cord. It's a very challenging condition. The best treatment for it is not to get it. However, it does occur in 5 to 10% of patients with systemic cancers. Often it's very fast onset of symptoms and significant loss of function. The prognosis, if somebody will be a paraplegic or not, really depends on how quickly the diagnosis is made and how quickly the treatment is. So if somebody is diagnosed quickly and the treatment is rapid, generally speaking, their diagnosis is better and their prognosis for walking afterwards is better than somebody had slow progression and it took a while until the spinal cord compression was treated. So in this table I summarized the article that I referenced below. So if somebody comes into the emergency and they're walking and they're diagnosed with a spinal cord compression related to cancer, they have 80% chance of being ambulatory as well. Versus if somebody shows up in the emergency as paraplegic as already with no motor or sensation, they only have about a 6% chance of being walkers again. So that's really how important it is to think about spinal cord compression when you work with people with cancer. And it's really important that it's not carved in stone. So those are percentages. I work with a lot of people diagnosed with lymphoma, and this is probably where one of my colleagues I work with said,
Oren, for whatever reason, I can't hear you right now. It looks like, I don't know if we've lost you. Let me look at the participants list here. Okay, Oren's backup computer is on. Oren is terrific because what he did is he put two computers on. So he's probably going to come back into the session with his other computer. Here he comes. Okay. Oren, we had lost you for a moment, so I'm going to turn the microphone back over to you. If you have trouble advancing your slides, I'll be happy to do that. And just tell me to advance them if you want them.
can you hear me now? Am I there? Okay, sorry about that. Can somebody maybe tell me where I can't advance my slides? I seem to have lost that ability. So, Jackie, I'll just mention when to move on, but I'm not sure where I was lost. So maybe if somebody can just say what. Okay, I'm not sure what's going on here. So what I was saying, that people with lymphoma are those that where we get really the miracles, and I've had many people with lymphoma who were told they could never walk, and they're up and walking now. So that's really important. So to remember, one thing I don't do is take hope away from people. Even if somebody really doesn't look and I don't think they'll walk, I still try and work with them. I'm honest with them. I may tell them I don't think they'll walk, but I still try not to take away hope. The next slide, please. As therapists, we should know cancer can metastasize to bone, to the brain. And often if we're working with somebody with cancer, we may be the first ones to identify some red flags, which I'll talk a bit about later, with people with cancer. If they were good yesterday and something really doesn't fit today, we may be the first ones who identify that. And I have been one of those who identified the metastases. Again, we don't diagnose it. It's how we communicate with the doctors and how we build their trust in us. But we are often ones that will say, oh, they're scissoring, their gait is scissoring today, and they had normal gait pattern yesterday. Or they didn't tell anybody, but they're losing control of their bowel and bladder. And I'll talk a bit more about those as well. And as I mentioned, really, early diagnosis can be the difference between function, however, also between life and death. and that's to some degree something I try to say, that as physios we do more than just function. If somebody's mobile, they're at lower risk for pneumonias, they're lower risk for sores, pressure sores. So really we do more than just function. We can affect life and death. Often if somebody is more functional, they'll get stronger chemo. So if we help somebody become more functional, then again they can get a higher quality treatment, which can affect life and death. The next slide, please. Thank you. So what do we do as physios? So really as physios we need to know about the cancer. We need to know about the treatment. We need to do a regular physio assessment. We may need to modify our assessment based on the cancer. So for example, if somebody has very fragile bones related to multiple myeloma, most likely I won't do manual muscle testing to see how strong I can get them working, because there's a good chance I'll break a bone. So we need to think about what we're doing, but really we need to ask them and we need to know. One of the challenges is sometimes patients do not want to know what they have, and they don't know if they have metastases, or if they do know they had metastases, they don't know where it went to. So that's, if we have access to medical records, we need to know that as well. If you have access to x-rays, it's good that you look at them. It doesn't mean you'll know exactly what you see, but it's good practice over time. And all that information really helps us decide and develop the precautions and contraindications before we work with these patients. Next slide, please. So some of what our patients tell us, they tell us if I exercise, my bones will break, and that no exercises are safer for people with cancer or people with metastases than other exercises. Next slide. Jackie, you'll need to be on top of things now. I'm going to make you work fast soon. So really there is evidence that people with bone metastases can exercise, and they can exercise safely as long as it's modified. So for example, again, if somebody has metastases in their femur or in the spine, we probably will not have them jumping up and down. We do want them to do some walking as weight-bearing exercises to strengthen bone, but we need to adjust our exercise. Water aerobics may be a good example. If somebody has humerus metastases and we want them on the treadmill because we know that they don't have anything in their femur, that may be okay. If somebody has peripheral neuropathy and metastases, we may not want them on the treadmill, because one thing we don't want them to do is be ejected from the back and then break a bone. So really, exercise is safe and we need to modify them. Next slide, please. A myth is if I wasn't exercising before, I can't exercise now, or I can't tell the difference between good pain or bad pain. Next slide. So really need to find a balance between monitoring and it's not needless anxiety, but a high level of anxiety. If somebody hasn't exercised before and we start them on an exercise program, they're most likely will be sore. So we need to teach our patients to differentiate between good pain and bad pain. If they exercise for the first time and they're sore for a day or two later and then it improves, it's probably not cancer related. However, if they have a bone pain and it's getting worse and no medications are helping with that, then exercise may be good. There's a question, what about going out of the water? Gravity sinks in fast. Need gradually exit from the deep water. I don't know of evidence directly on that. For our patients, if they can't come out of the water, as long as it's controlled, and when we talk about exercise, really that's the safe exercise, that's really the bottom line. Things need to be controlled, and that includes getting out of water, at least, but I don't know specifically evidence on that one. I'm going to talk a bit more about pain a bit later, but really many people with cancer are diagnosed with who weren't physically fit. When they learn about the benefits of exercise, they tend to be more physically fit after diagnosis. Not that we want to use cancer for everybody to stimulate them to exercise, but definitely there are benefits for exercise. Next slide, please. So some red flags. About 30% of people with cancer will develop symptomatic spinal cord metastases, and it is a common complication of cancer. Cord compression can happen, so somebody may develop metastases in their spine, in the vertebral bodies, but they may not have cord compression. So 5 to 14% will have, and as I mentioned, really, the sooner they get treatment, the better it is. Next slide. So, for example, these are most common primary sites for spinal cord compression related to cancer, so or primary types of cancers that will spread there, and breast cancer. So if you're working with people with breast cancer, and that's a very big population that we work with, you always need to worry about. And that's our job to worry, not necessarily the patient's job to worry. We need to pay attention to that. And the other cancers as well. As I mentioned initially, any cancer can go anywhere, but these ones tend to have a greater affinity for the vertebral bodies, and there's a higher risk for spinal cord compression. Next slide, please. So if somebody has back pain, and if you want, you can do the online voting, but I really don't want to challenge the technology. Who didn't have back pain? As physios, we work with very heavy people sometimes, so back pain is a challenge. Most likely it's not related to the cancer, and many people with cancer will have back pain as well, not related to their cancer. So if somebody has an acute onset, but it improves in a few weeks, usually if it's lumbar, 70% of sciatica will get better over a few weeks. Stenosis will not get better, but it's more related to wear and tear. It's most likely not cancer related. Next slide, please. It may or may not radiate. Some people up to half of the people with cancer-related back pain, it may or may not radiate, and half of the people may or may not be able to walk. 10 to 15% of the people will present with paraplegia. They may have sensory changes, bladder and bowel changes. Now, it doesn't mean this can't happen for people without cancer, but it's less common. And definitely, if somebody has a history of cancer, that's what we need to ask. And as physios, we may not always be comfortable asking about bladder and bowel, but we do need to ask about that, and we do need to pay attention to that. Next slide. If a person is less than 20 or greater than 55, we need to ask or worry, and they have a history of cancer, we need to worry about cord compression, and we need to keep that in the back of our mind. If there's a spontaneous onset, if somebody, I am in Canada, and at some point we will get snow. Many of you may not have that problem, but if I shoveled my snow yesterday and I have back pain today, most likely it's not related to cancer. If the pain doesn't go away, if it's in the thoracic spine, again, it can happen anywhere in the vertebral body, but it tends to happen commonly in the thoracic spine as well. If you take pain medication and it doesn't help, non-mechanical explanation to the pain, really, then we need to worry about that. It doesn't mean there's a cord compression or there's cancer progression, but we do need to consider that, and we do need to pay attention to that. Next slide, please. So if somebody, you're worried that they have cancer-related back pain, it's really important that they don't exercise until they have medical clearance. If they have back pain and no other symptoms, so no weakness, no loss of sensation, they have a history of cancer, you're worried, you're not sure if it's spread or not, generally speaking, I recommend that they go to the primary doctor, if it's a cancer doctor or family doctor, for investigation. But if they do have back pain and they do have weakness, they do have loss of bowel bladder, do have sensation changes, I tell them to go to the hospital emergency as soon as possible. And if there's a center close by that's related to that has expertise in neurotrauma in terms of spine surgery and anything like that, I recommend that they go there versus, for example, a hospital that specializes in something else. And as physios, it may be good for us to know which hospitals in our area have those expertise so we can refer our patients to there. Next slide, please. So I'm not going to go through the next slides. I'm going to have you read them and when you're bored. However, if you switch to the next slide, please, Jackie. There is a scale to when somebody looks at X-rays or different diagnostic imaging, how to diagnose metastases. Again, we do not diagnose them, but this is a common language we can use with physicians. So you can read through that, and you may or may not see the Mirels scale recorded in somebody's chart, and it is a scale that helps predict fractures. Again, we won't say to the patient that we expect you'll have a high chance of a fracture based on your knowledge, but we may but we may say that they are at a higher risk, and we may use the scale for our practice. So I'll leave it up to you to read. Next slide, please. Next slide. Next slide. So as physios, how do we treat people with metastatic cancer? So again, safety first. If we exercise with somebody and we break their bone, most likely they won't come back to see us the next time. It's not always true. Sometimes there's no choice, and not that we break a bone, but we try to move them and something happens, and then we still see them. But really, we need to remember the whole person. We need to be safe. If you're thinking if somebody has a metastasis in the femur, you need to remember that the muscles, such as the quads, attach to the bones, and if you work the muscle thinking the bone is safe and the bone has a metastasis to it, you just need to remember that you are applying pressure or forces through the bone. If somebody has metastases to the spine, we may want to educate them that twisting or jumping is not a good idea. So really, education is a big thing that we do. We also want to educate them about maximizing function and physical activity. I mentioned those who are more active tend to do better. There's evidence that, especially for breast cancer, those who exercise have improved survival. So those are important things we can educate our patients about. We may or may not provide gait aids. We may adjust it. So for example, if somebody has metastases in their femur, we may want to give them a walker with no wheel so they can take some weight off their leg, or if they need to be non-weight bearing. If they have metastases to their spine, we may not want to give them a standard walker because then they need to lift it, especially if their balance is poor. So they may be at a higher risk there. So which is the best gait aid to give them? It depends on the rest of the picture, but those are things as physios we need to think about. And there's no right or wrong answer. It depends what's available, what the patient needs, and other items they need to worry about. Next slide, please. We can use modalities. We can use modalities for pain control. Generally speaking, we won't, for example, use TENS or Coditron over a tumor, but we can use dermatomes, myotomes. We can stimulate sore areas from far, and they can be used safely to reduce pain. So if somebody has a injury in one femur, we can use the same area on the opposite side to stimulate with a Coditron, which is a type of TENS using acupuncture points to stimulate and try and block the pain. We can do exercises. Exercises may be, I'll talk a bit more about exercises soon, but they may be exercises for comfort or exercises for function. So we may do those as well. Some use treadmill for people who, even if they have femur metastases, and some do not. It depends where you work, what you're comfortable with, what the patient wants, how you use the treadmill, the type of treadmill you use. Some may be more shock absorbent than not. So those are things we need to think about and take into consideration. If somebody has femur metastases and the patient really wants to walk on a treadmill, it may be okay, for example, if they're walking on a level versus on an incline. So those are things we need to think about and how to modify our exercises. Next slide, please. So this table really shows that it's a summary of what exercise can do for people with cancer. I won't really go over this. I do that in different talks, and I know because of our technical challenges we're a bit behind, so I'll try to make up some time. But really, exercise can help a lot, and from my point of view, there's highlighted there is evidence that exercise can prevent cancer, improve survival, and reduce disease relapse. Next slide, please. Exercise for people who are short of breath. Next slide. Next slide, please. Oh, am I lost again? Oh, thank you. There's many causes for shortness of breath. It could be related to the cancer treatment, nutrition. You can read this at your leisure. Many of our patients who may have been smokers, so shortness of breath may not be related to their cancer as well. Next slide. Thank you. There is good evidence for medications to help with shortness of breath. It may be true help or a placebo effect. However, regardless, as long as it helps, that's what's important. Next slide. In this slide, I have the thumbs up and down. There's actually mixed evidence for exercise effect on shortness of breath. And thumbs up means there's good evidence. Thumbs down means there's some articles that showed no benefit. The important thing is, one is counseling. If you look at the bottom, there's evidence for counseling. The articles was on nurse counseling, but we can do a lot of that as well. Breathing techniques and positioning is something we can do as well. And not everything works or doesn't work for our patients. It's just different ammunition we have where we can work with our patients as well. So there is a lot we can do for people with cancer, also with lung cancer or cancer that metastasized to the lungs, and we can definitely help improve quality of life and function, but we need to help educate them about shortness of breath, and there is some evidence for that. Next slide, please. So these are just examples of different techniques we can use for them. You can read that as well. So we'll just go to the next slide. Next slide, please. The main thing that when we work with patients with shortness of breath, and the shortness of breath, if it's related to metastases or the treatment, their chemo, or they're just very, very deconditioned, is really that we understand them. And that's really good evidence for that. Just by listening, people tend to tolerate their shortness of breath and they trust us more. And that's really important, because we can, and we should, as physios, we work a lot with our patients, and we tend to understand them more. And when they trust us, even if they're short of breath, they'll agree to push their limits a little more. So there is evidence for the counseling, and we can do a lot of that as well. Next slide, please. So really, that's the end of my presentation. You have my email if you have questions. We have the oncology division in cancer in Canada. Sorry, talking about cancer. You can check out our webpage as well. And if you have any questions, you can type them in. You can always email me as well. And again, thank you for letting me talk, and hopefully that you enjoyed this or learned one or two things. That's it. I'm gonna maybe, oh, thank you. It's neat when technology really, really works. So it is fantastic. So feel free to email me. I'm gonna maybe pass the microphone to Jackie, and everybody, you're most welcome, and continue making our patients work. Take care.
Thank you so much for your presentation, Oren. For those of you that have not met Oren, he's actually the president of the Oncology Special Interest Group in Canada, and he's currently, as he mentioned earlier, working on his PhD in this area. So we'd like to thank you so much for your presentation, and also to let you know that you're going to be our inaugural winner of the International Scholar Award from the World Congress for Physical Therapy's International Oncology, Palliative Care and Hospice, and HIV/AIDS section. So we'd like to thank you and congratulate you on the work that you're doing. Does anyone have any questions for Oren? You can either type them in underneath in the chat room, or I can turn over the microphone to you if you have a microphone on your camera. So does anybody want the microphone? Okay, I see some people typing. Okay, Chi-Wee says, do physios have a role to play in breakthrough pain? Oren, I'm going to turn the microphone back over to you.
Okay, can you hear me? I think so. So I'd like to say we're great. We can do magic. Sometimes, really, as my patients call me, I'm a pain in the you-know-where. So they may need their actual medications before they see us. Saying that, we can offer acupuncture, at least in Canada where I work. I can offer acupuncture for pain control. You may or may not be able to do it where you work. However, if some of my patients are really in too much pain and they can't lie still for the acupuncture, so that wouldn't be a safe modality to use for them. Many patients don't want to take pain medications because they're worried they'll be addicted to it. And really, there is no evidence for people who are in real pain that they get addicted to the pain medications. So, unfortunately, well, I'd like to say we have more to offer when it's really breakthrough pain, but sometimes meditation and whatever can prevent the acute pains from where the breakthrough medication happens. So we may have a role there as well, but we don't have really good evidence for that as far as I know. There was a medication about bone marrow transplant and multiple myeloma. Unfortunately, with multiple myeloma, I always follow precautions for them, and they are at the risk for fracture. We definitely exercise them. We definitely do weightlifting with them. How much weight they lift depends on their lesions, depends on the philosophy of the doctor, depends on the patient, on what they want to do. So, for example, some of our doctors say that our patients shouldn't lift more than 10 pounds. But then they go home and lift their children, because if they have a baby, they need to lift them up at night, which is generally speaking more than 10 pounds as they grow up. So we also need to use common sense. So we may tell them how to exercise safely. And I mentioned slow and controlled. Most fractures for my patients did not, well, actually I never had anybody have a fracture while exercising. They do have a fracture when they sneeze. They have a fracture when they turn in bed, when they pick up a piece of paper from the floor. And the reason is they're not paying attention to their body. And generally speaking, those movements will be uncontrolled. So definitely there's a risk while they exercise, and we educate them about that in terms of informed consent. However, more likely than not, people with multiple myeloma or others will fracture when they're not exercising and they're not really paying attention to their body and thinking what they should or should not do. And Jackie added that she uses TENS for end-stage cancer, and we use it where we work a lot of acupuncture, or not a lot, but we do use acupuncture for people with end-stage as well, and some exercise for quality of life. So definitely there's different modalities we can use. Any other questions? You're most welcome. I'll pass it back to you, Jackie, if I get the right click here.
Well, thank you, Oren, again. And I welcome all of you for attending this session. I think as we go on, the technology is going to become better. So if you have any suggestions for us in the future, again, I want to let people know that we do have a website for the World Congress for Physical Therapy. And I will type it in here in just a minute here. It's www.wcpt.org and then /node and then, oh, I'm sorry, these are actually forward slashes. 49580 is our site, so anytime anyone wants to look at the site, you're welcome. I wanted to let people know also we still have positions open on the board for the treasurers, the education director, and the oncology special interest group, so if people would like to join us and help us with any of those positions. And then Deb is reminding me to say that our next session will be February 15th, and Chris Wilson, who's from William Beaumont Hospital in Troy and who's also our hospice and palliative care coordinator, is going to be presenting on February 15th. The time will be again noon, and it's, oh gee, I can't remember if it's Central Time or Eastern Time. Maybe Ann could refresh my memory. Ann Newstead is our treasurer. Okay, Eastern Standard Time. Again, all of these presentations are going to be recorded. It takes about the same amount of time for them to record themselves on this website as it took for them to be presented. So if you want to come back and visit some of the websites that Oren had presented, you're welcome to do that. Or if you want to share the recordings with other people, that would be great. So for right now, the only three things I wanted to say was visit our website, join us on the board, or come and visit us in February on the 15th at noon Eastern Standard Time for the next presentation that will be done by Chris Wilson. I see Chris is typing something, so I'll wait. Jackie, will the recordings be posted on the website, or where can we find the recording? Quite simply, you're going to click on the same website that you came to visit the live session, and that'll turn into the recording. So that's how you're able to get the recording. Does anybody have anything extra to add? I guess I'd like to know if we could take a poll. There's actually a green check and a red check below the names. If you have direct orders or standing orders for physical therapy when people receive a cancer diagnosis at your facility, could you check on the green arrow and then, the green check, and if you do not, if you could check on the red check. And we'll take a little poll here as to what people are doing. Okay. It looks like most people are not having standing orders. And I think I can publish this on the whiteboard. So let me go back to the whiteboard and publish our results. Does anybody have comments? Okay, here's the results. Most people, 7 of 14 do not. 2 of 14 do have standing orders, and then 5 of 14 didn't check in. And Deb's saying only with lung cancer patients. Nicola, we do not understand this question in England due to our NHS structure. Can you further explain? I'm going to let Deb take the microphone on this because she's been real successful with getting standing orders. And then Nicola, if you could you explain your structure? Do you have a microphone that you can explain your structure, and I can hand the microphone to you? I see people are typing here. NHS, National Health Service. Does that mean, Nicola, that you have access to patients without needing a prescription from a physician? Okay, it's free at the point of access for patients, so yes. Okay, that's great. We don't all have standing orders in this country. Deb, can I ask you to comment on what you're working on with St. Mary's, and then maybe Chris can comment about what's happening at Beaumont. So I'm going to turn away the microphone. Deb, you can have it.
Hi, Jackie. Yeah, and Chris, I think, is probably doing this more than we are, but we just started a lung cancer rehab program, and because in Michigan we cannot see patients without a physician's prescription, we always have to have that first in order to start treatment. So now, for any of our thoracotomy patients, the post-thoracotomy standard order set now says automatic referral to physical therapy. For us up in Saginaw, Michigan, this is a big deal because prior to this, we were not getting those referrals unless there was a problem. And we want to do a lot of the education. We do a 6-minute walk test with every patient, give them flexibility exercises, strengthening exercises, aerobic exercise program, and get them started. Every person gets a pedometer so that they can start keeping track of their steps right in the hospital, and then of course take it home, and then it becomes an automatic referral outpatient once they're discharged. This is really a big deal for us because we aren't getting those regularly, but this is the only population right now that we have the standard order set for. I'm going to turn the mic off and have Chris Wilson talk about their program because I think you're doing more than we are, Chris.
Chris doesn't have a microphone, but I do see where he sent back a message. We are also in Michigan, USA, where we need a prescription. We have a standing request from the nurse manager in the hospital as well as our oncology physician. The physio then reviews the chart and basically initiates the order per protocol with a standing order. So standing orders are beginning in Michigan, and a lot of it, that what we're seeing in our area is that it's up to the physios. Oh, and Chris Wilson has a pre-signed order. But again, it's up to the physical therapists to educate the physicians and the patients and the public on what it is that we do and what we can do for them. And so, you know, the physicians and even the nurses, we had a hospice nurse give a presentation in one of our classes last week, and she says, well, a lot of people don't know what the physical therapist can do, so it's up to us to you know, educate these people. Deb, I'm going to let you talk about how things are reimbursed. It looks like there's a question from Chris Campbell. So here's the microphone, Deb.
Well, reimbursement is on an inpatient basis. You know, somewhat depends on their insurances, and you know, a lot of different diagnoses are paid one lump sum for their hospitalization, which also includes physical therapy. Sometimes physical therapy is a separate charge. So these are all insurance-based when it's an inpatient basis. On an outpatient basis, then you get you also have the co-pays that patients have to pay out of their pocket. Maybe Chris Wilson could talk about that from his perspective too. But I have a question for you, Nicole. So it's automatically that you are part of this, that a patient can have physical therapy once they're in the hospital, but are you limited with number of visits? How do you determine the number of visits and how much time you'll spend with them? I would be interested in that, and I will turn the mic off.
Nicola, if you have a microphone on your computer, I can hand the microphone over to you and you can talk on the microphone. If you could maybe send me a message through the chat if you'd like me to turn the microphone over to you. Okay, that's all right. So just type in your answers in the chat room. There's lots of ways that we can get this to work, even by sending smoke signals eventually. So I'm just going to wait for Nicola to answer Deb's questions. I see she's typing here. While she's typing, I just wanted to let people know that we are updating our system, and hopefully in the future we'll be able to have more people with their pictures. Okay, Nicola's responding. We see all patients referred by any member of the multidisciplinary team. This is great. We don't have this luxury yet in this country, and I think it's important that we internationally can talk to each other and collaborate and learn from each other. So Nicola's also saying we do not specifically require a consultant-led referral. All right, does anybody have any further questions or comments that they'd like to provide for us? Okay, Anne is asking Nicola what country she's in. She's in the UK, the United Kingdom. All right, is anybody brave enough to take over the microphone that has a microphone that wants to contribute to the discussion here? Okay, I don't see anybody typing. All right, I guess what I'd like to do is just let people know that I really appreciate you all coming to this session. We're hoping that this is going to build international knowledge and wisdom throughout the group. And our next session again will be February the 15th, and that's going to be at noon Eastern Standard Time. And Deb is saying, thank you so much, Jackie, for your leadership in the oncology section with the World Congress for Physical Therapy. Thank you so much. I couldn't, accomplish any of these things without all of our board members and then without all of your interest. So again, if there's no further comments, I'm going to be signing off and wishing everybody a fond farewell.
One, two, three, testing, 1, 2, 3. Can you hear me, Jackie? Oh, okay, so my mic does work. So that's good. That's good to know. All right, great job. Glad everything went well. I'll talk to you later, okay? Okay, well, have a great day, okay? All right, thanks for looking at the certificate. I'll talk to you later. Thank you for getting on my mic. Okay, bye.